This is Peter, a 103-year-old male who sustained a significant injuries to his leg. He developed cellulitis, an infection of unknown etiology. They first thought it was blisters or some sort of exposure to either poison ivy or some other material while he was gardening. He became septic and was in the hospital. He was treated aggressively with antibiotics. The family was not pleased with his prognosis in terms of what the doctors had said. They had informed him that they have a very small chance of surviving. They brought him home. They wanted to have him at home, at least if he was going to pass away, that he would pass away peacefully in his own home with family. But they also were very aggressive in terms of resources and care. They brought him to New York City, even though he lives in Massachusetts. They wanted to pursue all of the appropriate avenues in terms of healthcare providers, nursing, and so forth, as well as physical therapy. Before he entered the hospital, he was very functional. He was walking around, gardening. He was actually even commentating on sporting events. He had a very fruitful life, and he developed these awful wounds. When I first started seeing him, he had these necrotic infected wounds on his leg. They covered about 80% of his leg. I did 2 surgical debridements. We then changed the wound care. They were using a contact layer called Zeroform, which is a very sticky dressing, but doesn't really do much in terms of managing drainage and cleaning up the wound. We use a combination of Santal, which is collagenase, as well as hydroferroblue, which I've talked about in previous videos. Right now, we've had a major improvement of these wounds. They went from being extremely large wounds taking up the entire leg to only one very small wound on the ankle with some tendon exposure. Approximately 4 months ago, he went back to his home in Massachusetts. He's been traveling. He does come every probably 2 months back to New York City, and they wanted me to come by to see him and to remark on his progress as well as make any recommendations. There currently is a visiting nurse coming 2 to 3 times a week. They're changing this on a regular basis, at least every other day. The private caregiver is managing some of the wound care. Right here, I'm looking for supplies to see what they have. They were using Aquacel on the wounds, which is not my recommendation for a chronic wound, even though it's a great dressing, which I'm explaining to the caregiver, Paul, as well as the patient and the daughter. It's not something I routinely use in a wound that's not draining. Aquacel as well as alginate dressing are great for draining wounds. This wound is not draining, nor does it have significant hypergranulation tissue. So right now we're looking for a collagen material, which we had used previously. I like collagen products such as Prisma, Puricol, or Epiona, which is my personal favorite, because they lay down a matrix for wound healing, particularly for chronic wounds. Sometimes I recommend skid substitutes or biologic dressings such as amnion or placental grafts. This one didn't need it since we were really at a miraculous improvement. You see right there, I have a collagen powder. I was thinking about using a collagen powder during this visit, but I think it'd be much easier to manage both for the caregiver, the nurses, as well as just to continue with a sheet of Puricol, which is a collagen matrix. I'm cleaning the wound here. Unfortunately, some of it is out of the picture, but there you can see it's a very small ankle wound. The leg is a little bit swollen. What I was told by the caregiver as well as the patient and the daughter, that they're no longer using any compression. In these patients, particularly when they get older, and even though he's a very functional 103-year-old male and he's remarkably astute, your blood flow to the foot, meaning your arterial system, as well as your blood flow back, which is part of the venous system, can always be impaired, particularly after traumatic events such as infections. So I always recommend some sort of compression, either an ACE bandage or Coban. I didn't use Coban on him since it's a little bit more difficult for the caregiver as well as the nurse to use. I think ACE bandage is reasonable. So that's why I think that the leg is swollen. Also, he's much more active. So that's another reason why you see what you're seeing. The area above on the top portion of the skin is all kind of healed up and scarred up. It's hard to appreciate based on the video, but in person you can really see that it was a large wound. There's some dry scaling in between the ankle wound and the knee area, which we can treat with a moisturizer just to give him some moisture, even though there's no drainage. So right now we put Puricol down on the wound after cleaning it. I'm looking for other supplies. As you can see, I didn't come perfectly prepared like I normally do. Thank God the caregiver knows where everything is and he's helping me. The daughter's in the background. After the Puricol, we're using just gauze, and we'll wrap it with either Curlax or something called Cling, followed by compression. I'm explaining everything to both the daughter, the patient, as well as the caregiver, my thought process. I'm happy to talk to the nurses. A lot of the time I encounter that there's not good coordination and collaboration. So I'm really emphasizing the importance of consistency, collaboration, and coordination, which is my other motto in terms of my new motto. Instead of the 4 Ps, the 3 Cs. We're elevating the leg here. I can do it by myself. He's actually very reliant. Unfortunately, he's kind of turned over. He is comfortable. he can sit up straight. We're just trying to do this in a facile way. On his bed, I've wrapped the leg up all the way with Curlex, as you can see the top portion. Unfortunately, the video doesn't show the bottom portion. I'm conversing with them about, the whole thought process of doing compression. The daughter and I are even talking about most patients should be wearing compression socks. I wear compression socks throughout the whole day because I'm on my feet. So anyone that's older definitely should look into it. I wear it for 12 hours a day. We're wrapping ace bandage all the way from the toes all the way up to the knee. Anything less than this will leave what's called the tourniquet compress, can compress the leg or the ankle and lead to swelling of the foot, which we want to avoid. That's why I start from the toes and go all the way up to the knee, as you can see here. What's nice about this ace bandage is it's self-adhering, so there's an elastic bandage with Velcro. I'm explaining this to the caregiver who can do this himself. This should be changed every other day. The nurse was telling me it can be someone only changed once or twice a week. I don't recommend that. I also recommend that he can shower but take the dressing off. He's generally showering every other day, so they can take the dressing off, have him go in the shower and bathe, which is fantastic. I'm explaining that we need to keep his legs elevated at all times. We're going over all the mechanisms in terms of why leg elevation is very important. So I'm very happy that he's aggressive with the walking, which obviously the leg is in a dependent position where it's hanging down, which can lead to swelling. But when he's not walking, he should be keeping his legs elevated. And it's really important to have some sort of compression, in this case, an ace bandage. They seem to agree. The caregiver nor the daughter have any issue with the ace bandage. They just really want everyone to be on the same page. Going back to the 3 C's, which is consistency, coordination, and collaboration. And we will see them in the next 2 months. And they're really happy with our progress.